Sure, I'm happy to start. Um, so appreciate the invitation to talk with folks affiliated with UConn and Yale. One of the reasons that I like to do these kinds of presentations is to really offer myself and our division as a resource and make it perfectly clear that you should contact me, contact us at any time if you have questions about the process, research ideas. And so, although I can't see you all right now, and optimally, this would be interactive, I do encourage you because I've been told that you can share questions that if you do have any questions that come up during the presentation, we'll have some time for question and answer at the end, but also feel free to send a question. I don't mind being interrupted, and Aaron, who's at UConn and coordinated this, can feel free to let me know of any questions that come up along the way. That's really the way I like to do this. So that said, um, there's really three major things I wanted to accomplish today. One was just to, because I understand that there's a range of folks who may be watching and listening in, um, graduate students, faculty, and others. And so some of you may be more or less familiar with the kinds of work that we fund. So the first thing I really just wanted to let you know was the range of work in the HIV/AIDS space that we support. The second is to um, introduce you to the people and the people responsible for the various programs in our portfolio. And the third is um, um, to talk to you about the reasons why it may be helpful to contact a program officer. Again, in the interest of encouraging you to be in touch, I can let you know some things that we're able to do in our position that you may or may not be aware of. So I have many slides that I can walk through, more slides than I can go through. I'll go through quickly some of them, but I just wanted to provide them so that you had them as a resource because some give contact information, some are web resources, and so um, I'll start there. Uh, so just to provide a little bit of context, NIMH is one of 27 institutes and centers that fund work under the auspices of the OAR research priorities. The Office of AIDS Research is the entity that coordinates all of the HIV/AIDS research across NIH and really helps us set our priorities within that. So our mission falls within um, reducing the incidence of HIV, research towards a cure, and comorbidities. You know, one thing I should say at the outset, when I do presentations about the NIMH Division of AIDS Research, those who are less familiar with what we do think that that means that research that we fund must be related somehow to mental disorders. And although it may be, that's not required. That's not the case all the time. In fact, we fund a range of research from basic science all the way through implementation science. A fair bit of our work is in the behavioral and social science space, but it doesn't necessarily have to do with mental disorders per se. One thing about this slide that I just wanted you to pay attention to is that when these OAR priorities came out, in 2015, there was some concern that there were some words that were absent from these priorities. And the leadership at OAR has underscored that behavioral and social science clearly cuts across all these different priority areas. And so we're not going anywhere and our priorities aren't going anywhere. And so as I go through, it'll be clear the spaces that we're most interested in supporting. So these are our overall goals and our mission, and you'll see as I work through the portfolios that we support, there is about 40% of the research that we fund is in neuro HIV, and then behavioral and social science makes up the other 60% of the research that we support at this time. So here's our organization, we have 3 branches. I am the branch chief of that center branch, the HIV prevention and care continuum comorbidities and translational research branch. It's really a lot of behavioral and social and implementation science that focuses on folks living with HIV.
Has joined the meeting.
Welcome. I will tell you a bit about the basic science, which is the clinical and therapeutic science in neuro HIV. And then I'll tell you a bit more about the developmental HIV prevention and treatment branch. So to start with, here's the folks, Jay Mahan Joseph, Vasu Rao, and Deb Colosi, who lead up our neuro HIV research program. Jay Mahan is the branch chief, Deb has the therapeutics program, and Vasu has the mechanisms of neuropathogenesis program. I am a psychologist by training and a behavioral and social scientist, and so if you have any specific questions about their priority areas, I encourage you to contact them. They're as accessible as I am. And here's some brain domain highlights. I don't know that they list their FOAs. They don't. I'll show you at the end. Pim Browers is the branch chief for the developmental and clinical neuroscience. They host much of the work that we fund in the pediatric and adolescent space. So some of you may know Susanna Allison, who leads much of our adolescent work. David Stoff is the individual who's responsible for leading our aging and disparities program and our training program. So if you have questions, for example, about doing a predoctoral F31, David would be your initial contact, but then you'd also work with one of us in terms of the programmatic or scientific work that you want to fund within the F31. Pim Browers, who heads up our clinical neuroscience program, focuses on the neuropsychological sequelae of HIV. Hi, someone entered the room. I'm just saying hello to see that you can hear me in the room.
Gotcha.
Hi there.
Hey, it's Lisa Eaton. How are you?
Hey, Lisa. Good. Good to see you. It's nice
Sorry,
to
I had kindergarten orientation this morning, so I'm just getting in.
understood. So the other program that's hosted in this branch is work around pediatric PMTCT and the adolescent research program, which focuses both globally and domestically. Domestically, as we focused on those at highest risk for HIV, tends to focus on young MSM, particularly minority MSM. Although recently Susanna led an RFA that was focused on adolescent girls and young women in sub-Saharan Africa. This will continue to be a priority for us. Obviously, the highest rates of incidence and prevalence remain in sub-Saharan Africa. And we get a good response to RFAs in this area in both the care continuum as well as adherence to HIV prevention. And Lisa, by the way, I did encourage folks both to send questions to Aaron and to interrupt if they have questions along the way. I wanted to keep this as informal as a webinar can be.
Okay. Perfect.
These are some of the priority areas that David Stoff has in our Aging and Disparities research program. And here's an example. I should have said at the outset also highlight here and there some studies which are recent findings and sort of exemplar work that you can look at that sort of gives a flavor for the kind of work that we support in each area. So this is the branch that I'm responsible for, as I said, which covers the care continuum, comorbidities, especially mental health, and implementation research, which cuts across all of the OAR priority areas. Before I get into the specifics of the kind of work that we support in this branch, this is the part of the presentation where I really wanted to emphasize, underscore, encourage you all to contact program officers early and often as you're thinking about the kind of work that you want to propose. And there's a range of things that we can do. We're really in a position to shepherd the science, give you technical assistance on specific aims. One of the things that happens as we work in this time of flat budgets is that we want to support work that is complementary to the work that we're supporting. And so you may have a terrific idea for a study, and we may be funding a couple of studies which are quite similar. And so, in the interest of spending our dollars most widely, um, I would never discourage you from submitting work. What I try and do is to help you shape the work in a way that either adds an innovative angle or is not redundant with the work that we're supporting. The other way that I can be helpful is that I realize that it's challenging sometimes to figure out where your research fits across the many NIH institutes, and so you may be interested in the intersection of HIV adherence and also have interest in substance use and mental health issues and alcohol, and it may involve adolescents. And so you may be wondering, what institute do I reach out to? And so what I offer is that, and I would suggest that all the people in our division are the same, is that if you reach out to us and you have a research idea, we'll first try and figure out if it's a good fit for our mission and priorities. But if it's not, then we work closely with the program officers across the different institutes so we can try and help you find a home somewhere. It's really important to find a advocate and a supporter for your work at one of the institutes. Um, we'll also help you talk through, your project may be ready for an R21 or an R34. We also may talk to you if it seems that a career award may be best according to your developmental trajectory. I think sometimes the other thing that we can be is pretty candid in trying to help you sort through whether your project is competitive, whether you're a competitive applicant, and we really try and do that in a way that's supportive and objective. But sometimes I think we might be able to do that in a way that's, oops, a little different than you might get from your colleagues and your mentors who want to encourage you to submit, but we can also try and give you some frank input about how to shape that work in a way that's going to be most successful. We also are able to attend the scientific review meetings, and so that also gives us a feel for, there are a couple of main HIV/AIDS committees that all of the work that you would submit would be reviewed at, and we're familiar with the culture of those committees. We can try and give you input on the kinds of things that typically trip up applications that go to those particular committees. And so once a project is reviewed and you get your initial summary statement, we can also help you try and interpret those, reply in a way that's responsive, give you a feel from hearing the discussion in the review, what seems to be the most weighty or important issues that were weighed in review, because that may not be apparent on the summary statement of the paper you receive, but we can help to read between the lines and how to be most responsive. So when do you have to? We always encourage you to contact program, but you have to if you want to do a large budget project, if you want to do an R13 conference grant, when a letter of request a letter of intent is requested, but it's always recommended when you're applying for any grant. A couple of miscellaneous tips. There's a NIH report, which you may or may not have access, which shows you all of the research that we fund. You can get a feel for the currently funded projects. I mentioned that we try and support work that's complementary to what we do. So there's one way that you can look at that yourself before you reach out to us. When you reach out to us, by the way, I'll generally give you a tip in that uh, when you send aims, when you request any information, I think it's important as soon as possible to try and set up a telephone call. I like to try and talk to someone through their ideas, their concept. And so setting up a call, I mean, it gives me a feel for where the person's at. And I think it sets up it's really an ongoing dialogue that we have that I prefer to have over the phone rather than via email. Um, Here, just a slide with some other tips in navigating NIH. One tip, I'm not sure if it's in here or not, various grant writing resources. One tip is that institutes, before they do an RFA, which we're not allowed to tell the field about or anyone in particular, let's say we're going to do an RFA in calendar year 2019, those will have to be cleared through our council. And so if you go on our NIMH Council website, which is publicly available, you can see concepts that have been cleared. For example, this coming May Council in mid-May, there will be some concepts cleared, which means that Council has approved for us, if we have funding, to advance the following RFAs. And all institutes have to do that. So you can get really a preview of likely areas that will be of highest priority with set aside funding. RFAs, which are requests for applications, are important to think about when you want to apply because those are set aside funds. Um, our funding opportunity announcements, our FOAs, which I'll show you at the end of the presentation, do not have a set aside. Those are the ones when you talk about scores and percentile rank that we try and reach as much as possible, but they go into a collective pool. Feel free to sign up for the Inside NIMH subscription. That's actually a cool way to receive information about various highlights and new funding opportunities. Here's us. Those are pictures, I guess, of when we were younger. Um, So this is me, Greg. Greg leads up our HIV testing program. Mike Starrett, our adherence to treatment and prevention, and Terry Sen, our comorbidities and prevention and treatment program. All great folks. Reach out anytime. And if you're not sure who to contact in my branch, feel free to send a message to me and I'll figure out who best to be your primary contact. So these are a few of the highlights for high priority areas for us. Don't think that these are going to change in the near future. This is really both where the field is headed and our particular niches that we have particular, I think, expertise and ownership of across the institutes. Um, I'm sure you're all familiar with the care continuum. We really try and address each juncture in the continuum. We continue to foster work that I would say two of the most important areas in here are in linkage to care and in long-term retention and care. I mean, these continue to be areas where the evidence base is still surprisingly thin. I think we've done a good job in developing and implementing interventions to maximize the yield for testing, particularly in the US, but the evidence base for how best to help folks stay in care over the long term still needs quite a bit of work. And so these are going to continue to be high priorities for us. I mean, there are novel biomedical interventions that are important for both prevention and treatment, but these it is really human beings. It's men, women, and children who have to navigate these processes. And so there isn't a magic biological bullet. It may be in our lifetime that there's a vaccine or a cure, but in the meantime, we just have to do a better job sorting out how to help folks stay in care, both for their own health and for prevention. I wanted to highlight a couple of RFAs for areas that also are indicative of our priorities. Pretty interesting work that's not going to go away for us. These are a mix of projects that are funded to look at innovative measures of medication adherence, including a pill sensor, which sets off a signal when it's ingested. We are continually looking for new ways to objectively measure behaviors. It is probably the case that moving forward that studies that rely solely on self-report for any behavior, whether it's retention and care, whether it's someone's virally suppressed, whether someone is has used an HIV self-test kit, we want to complement those measures with some other objective measure, and that's, I think, increasingly become a trend in the field that we follow. Um, the HIV care continuum is non-optimal. The care continuum for mental disorders um, is abysmal. And so when you look at the intersection of mental health and HIV, so this is just the depression cascade for US HIV patients, and you can see that relative to HIV, those that are recognized clinically is poor, that get on appropriate treatment. And so when you look at the difficulties of mental health problems with people living with HIV, we're continually trying to figure out um, how best internationally to task shift for mental health treatment in the integration with the HIV care setting, and to look for novel ways to encourage uh, testing or screening for mental disorders, and then trying to figure out how best to help those folks navigate both HIV care and mental health care. The folks in my branch can tell you that there are many different mental disorders. Each one of them has some unique effect on both HIV and prevention and treatment. And so the mechanisms that you would try and study to understand, for example, the role of bipolar disorder in long-term retention and care would differ from the mechanisms that you would explore if you're trying to understand the influence of trauma in HIV care or the utilization of HIV prevention. So um, even though we've been supporting a lot of work for a long time in this space, I actually think that the pendulum has swung back some, so that um, there is a significant focus on the field in achieving the 90-90-90, the 90% of folks tested, linked to care, and retained in care. I think there's going to be increasing attention now on the 10-10-10 or the 20-20-20, and that's the folks who are going to require more resources, more attention, more intervention in order to navigate the care continuum. So um, it may be that there's not going to be a quick fix for those challenges as well. Um, for interest of time, I'm not going to spend too much on the range of studies that we're interested in the stigma space, other than to say that uh, it is both intellectually interesting and quite challenging to navigate HIV prevention and care, given both HIV stigma, but also the intersecting stigmas. So work in this area has become increasingly sophisticated, looking at the roles of both internalized and externalized stigma, and the unique and the pathways that it takes to influence adherence. And so again, this is just one example of a study that we support through an R01 to Janet Turan and her team. Um, but you can also take a look at both the studies that we fund in NIH report and reach out to Greg Greenwood in my branch, who leads this area, to because we're funding a bolus of work in this area to figure out a unique piece that you might explore. So I'll finish talking about our branch here with implementation science, which I've tried to coordinate our investment in over the last 10 to 12 years. This is clearly a high priority. And I'm a psychologist by training, I mentioned, and so I've come to learn implementation science over the years, as you can. There aren't many training programs in the U.S. to get an advanced degree in implementation science, but there are many training resources available. And if you reach out to me, I can let you know about various opportunities for folks who want to work in the space. And this is just an example of a study that we're currently funding in Uganda and Kenya to Alvin Gang and his colleagues to explore um, a sequential multiple randomized approach to try and assess the both proactive ways to prevent dropping out of care and then using a variety of increasing resources to get patients back into care. And so in the end, they'll be able to evaluate both the individual and the sequential impact of these interventions and really provide real-time input to those sites where the work is being done. So a while ago, folks used to talk about the lag between science and practice, but when you're doing implementation science in intervention clinics, they don't necessarily have to wait for the publication to know how they might modify and tailor their practices for men and women who are receiving treatment in their clinics. We're increasingly working with PEPFAR. You know, in the U.S., we work lots with the CDC and health departments and CBOs that are funded by CDC. But I encourage you to, if you're thinking about international work, to talk to us about um, priorities to ensure that the research that we fund meets the priorities on the ground. It's really critical to PEPFAR leadership is ensuring that research that's proposed is on a bit of a tighter timeline and provides more immediate input. They're looking for answers to help their practice in
Has joined the meeting.
short term. Welcome. Um, I'll go ahead and skip that. So uh, I'll just add a couple of slides here towards the end, which, you know, we have lots of resources online that you can access to both, again, see the program context, see particular, I whipped through the priority areas, but there's much more information available online that you can access, including our various programs. And that's where you'd find our standing funding opportunity announcements. Those are really standing iterations of our highest priority areas. But in
Can
some
you go back
areas,
one slide?
say again?
Can you go back one slide?
Sure.
One more? Yeah, what's this?
This is an example of a Fogarty-led cross
Oh, I think I
NIH.
know this.
Say again?
Okay, no, sorry. I thought this was coming up this summer, but I think I do know what this is. I just see now that this occurred last summer. This was the international stigma thing.
Correct. Correct.
Okay. Sorry, I thought this was an upcoming event. I wasn't sure if it was related to what we're doing in Miami at the, because we have a stigma-focused pre-conference at IAPAC, and I thought, oh, is that? But it's not.
I am glad that you're involved in that. For those
I'm
that don't
excited.
know, what Lisa's referring to is the adherence conference that we've been highly involved with for years that is in Miami in June. There's a
Yep.
couple of pre-conferences that we're hosting, one focused on stigma and one focused on the intersection of violence and HIV, the HIV care continuum. So go to the IAPAC website to take a look at those, and if it's not too late, see if you can attend. That's another example, by the way, of both having an opportunity to meet our program people in person, but also to see in real time what one of the things that'll be highlighted at a conference like that or a symposium like that are areas that we're really encouraging people to take a look at based upon what the field is already learning. So great that you're involved in that, Lisa.
I'm excited.
Yeah, me too. Um, Website resources. These are the funding opportunity announcements that I mentioned. Um, but again, I will note that if you were to click on any of these, if you were to click on the innovations in the care continuum, you're going to see a long list of potential areas. And that's why finding a funding opportunity announcement that highlights areas that we're most interested in is sort of step one, and then reaching out to the contact person who's on there is step two to get more tailored technical assistance to the direction that might be most useful, both for your research and for your career. So we really try and be as helpful as possible. So here is our contact information for the program folks in our division. And I realized that I went through a lot of information fairly rapidly, but I wanted to make sure that we had some time available for question and answer and discussion. That's really the way that this can be most useful to you individually. So I'll stop there, say thanks for joining this call. This is a start of a dialogue. I'm accessible here. This is my office. You can contact me here anytime. So let me stop there and say, Aaron, any questions that you've received yet?
Yeah, I just received a question. I just sent it along by email, so if you'd like to take a look. It's from Elaine O'Keefe from the Center for Interdisciplinary Research on AIDS at Yale University. Um, did you happen to get that email?
I have not.
You just read it.
Okay, I can read it along. I'll read it aloud
Sure.
for you. So it says stigma continues to present as a significant deterrent to HIV prevention and treatment goals. For example, in statewide Getting to Zero and similar 90-90-90 initiatives in our region in the Northeast, this is ever present. Can you say more about the stigma collaborative you mentioned earlier in your presentation and how we might connect? Elaine.
I wonder if it's that same slide that
Yeah, because I don't think I saw anything. I
Lisa.
took pictures as you mentioned stigma stuff, but I think that's the only one I saw that.
So Elaine, thanks for the question. The
Yeah. The
that
IMH
that
stigma.
I think what you're referring to was this trans NIH stigma funding opportunity, which really actually crossed um, disease areas as well. As you know, stigma is a barrier to mental health screening and treatment as well. Oh, there's the question as it came across. Um, so there is not a standing stigma research network per se, other than the fact that there are a number of researchers that we're funding in this space that we encourage to connect. And so as I said about the adherence conference and the symposium that Lisa is going to participate in, I'm trying to connect with the network of folks who are working in this area um, would be helpful. And feel free to reach out to Greg Greenwood to get more specifics about that.
I think too I think this is accurate. The Trans NIH Collaborative on Stigma was wasn't that focused in low and middle income countries, and was that and there was also, I believe there was an RFA or there was a PA, and I think there's going to be another one coming. Is that true?
Yes, there was an RFA.
There was, I thought there was another PA out. I don't know. I thought those were all related, but you would definitely know better than I.
There's definitely a standing funding announcement that we have that iterates our priorities in the stigma space. Yes.
Okay.
Looks like Elaine, she just emailed me again. She was referring to the stigma collaborative that was on the slide with PEPFAR.
Yep.
Has left the meeting.
That's what we're talking about.
Yeah.
Okay. Can I ask questions?
Yeah, please.
Can folks on the phone also hear Lisa's questions, or do I need to restate them?
That's right. She can. They can hear.
Oh, great.
Okay.
So feel free.
Oh, I'm excited. So
You have the floor.
I know. Kind of worked out to my advantage. How are you feeling about funding? So I'll just tell you how I feel, and you know, correct my inaccuracies or accuracies. Um, I was excited that we got a budget, so we're no longer in a continuing resolution, I believe.
Correct.
That makes me excited,
Has
given
joined the
that
meeting.
I apply for NIH grants.
Hmm.
And so I understand that that money might not end up beefing up an HIV prevention budget. It could go to like Alzheimer's or opioid use or cancer or whatever. But it does give me hope. So, for example, I have a grant I'm waiting at the 10th percentile,
Hmm.
and I'm like, it's it's kind of, and it's been sitting there, I think maybe like 6 months now, and it's kind of alarming if things can't get funded at the 10th percentile. Um, but I'm feeling like I should be hopeful. I mean, I guess how are you feeling about funding for HIV prevention and treatment work at this point in time at NIH?
I can give an example of how I would encourage an early career investigator,
Yeah.
which is to say that I still am of them. So we have as I said, a flat budget, which is
Right.
actually a success in
Yeah.
because I think everyone has relatives, including Congress people and senators who might have um, Alzheimer's or diabetes
Right.
or cancer, so that the research at NIH seems to be more protected than, for example,
Has joined the meeting.
PEPFAR funding or CDC funding.
Right.
Um, and although HIV no longer is required to be 10% of the
Right.
NIH supported funding, our pay lines have not changed drastically over the last 3 years. Unfortunately, what happens because of continuing resolutions is that if we have 3 pay periods over a year and we
Right.
don't know what our budget is, then we have to fund more conservatively in the first and second cycles because we don't know what the total pool of resources is that we'll have, which creates the kind of anxiety that you and others have
Right.
when they're waiting and unsure whether the funding will come through. What has happened, even when funding has been delayed, and I'm going to say over the last 3 years, is that we have been able to reach at least to the 10th percentile, and in most years out to the 15th percentile.
Has
That,
left the meeting.
that's no guarantee that something between the 10th and 15th percentile is guaranteed to get funding, but that means that we've done a pretty good job of being able to reach projects in that range. The other reason I should say that it's important to have program staff enthusiastic about your particular research direction and making sure that it's the highest priority is that we also do have some discretion in what we select to fund, particularly in that 10 to 15th percentile range. And so there may be some projects in there that get a good score at review that we may only be moderately enthusiastic about for one reason or another. And essentially a project that gets a slightly worse score at the
Yeah.
15th percentile as opposed to the 11th percentile, if we're highly enthusiastic about that project, we also can fund out of order. Um, just another aside about why I think it's useful to both make sure that your work is the highest priority and connecting with a program person. So in general, I still firmly believe that the best science and the best ideas we are able to fund. It is very rare I still see where um, an excellent project that's high priority um, isn't able to get funded after a couple of tries going through review. That just means that some of the work may be lower priority. Some of the work may not be um, as exceptional in its quality, but we're still able to fund quite a bit of good work.
Right. Um,
Chris,
Yes.
this is Steve Schenzel.
Hey, Steve.
How you doing, Chris?
Good. How are you?
I'm good. Uh,
Yeah.
Tuan Ha, who's sitting next to me, and I are, and Gene Schenzel are involved in developing a project in Vietnam. And among young women workers in the export processing zone,
Mm-hmm.
which is characteristic of many low and middle income countries. Uh, we've been in touch with Susanna,
Mm-hmm.
and she's been extremely helpful.
Mm-hmm.
One issue that's come up is the criteria that OAR establishes for determining HIV risk. That is, it would seem that they would like that simply the behaviors, sexual risk behaviors, aren't good enough. That there needs to be established a level of HIV that's significant enough to create HIV risk. The problem is that in this particular population, that work hasn't been done in Vietnam, but it has been done in China, for example.
Mm-hmm.
Um, that whole process of satisfying HIV risk could you comment on that?
So just to provide a little bit of context for those that might not know how OAR has changed a bit really since 2015, and I'm going to just tweak what you said a little bit, Steve. There is a process now after projects go through our council. So not before, but all the way after our technical assistance, something going through review, something getting a score before we can fund it. The Office of AIDS Research has to determine whether it's HIV related enough. And that is, for example, that it doesn't just focus on sexually transmitted diseases, that it has, so for example, a project could also focus on HIV and malaria, where malaria is really the primary focus of the project and HIV is secondary, and they may determine that it's not 100% HIV related. Therefore, we wouldn't be able to fund it because we don't have funding streams that can use both HIV and non-HIV related dollars. So when you refer to the OAR determining the quote unquote HIV risk of a process, and that self-reported behaviors may not demonstrate HIV risk concretely enough, that shouldn't be a process that the Office of AIDS Research does. We should be able to help the applicant um, try and develop projects, measurements, methods that most objectively can assess behavior and behavior change. Self-report can be a part of it. Increasingly, what review committees are looking for is um, additional measurement that may be more objective. But in terms of the HIV relatedness, I would say that a project like that shouldn't have a problem with the Office of AIDS Research. It may have a challenge getting through review committee. And those are two different things. But what you described to me in terms of the young women at risk for HIV in Vietnam is that is HIV related enough for us
Mhm.
and the OAR.
Do you have any recommendations about innovative approaches to move beyond self-report?
Um, there is that we actually had a meeting that Susanna should be able to give you the recommendations from. This was about a year and a half or 2 years ago about people who are doing some innovative work in that space. I would just say that in the meantime, before that technology catches up, I mean, there's a couple of ways that folks go. They augment their assessment, for example, with STI testing. But the other thing that they do is when you're I don't know what your particular project is after, or what the key questions are, but we often can encourage applicants to fold in a look at HIV testing and the prevention menu that those individuals might have.
Mhm.
So it's not their sexual behavior per se that you're trying to track and assess, but another piece of the prevention continuum, which may be more objectively measurable.
Yeah, that's a good thought. Thank you.
Yeah.
Um, I had another question for you. Can you talk, because a lot of my work, I think a lot of my future work is going to be looking at PrEP-related stigma,
hmm
stigma as a barrier to PrEP uptake. And you mentioned the DREAMS project. I think that was the only thing you said about PrEP. I'm not familiar with the DREAMS project.
So I could have spent a lot of time and I have whole slide sets devoted to the number of studies that we're already funding. It may now be up to 30 domestically, internationally, trying to sort out how best to increase uptake, adherence, and sustain PrEP use in a
Right.
variety of populations. Um, the Dreams Project is a uh, internationally funded project focused on 8 countries in sub-Saharan Africa where PrEP is being provided to. Dreams is focused on young women. And so I can't recall whether that's OGAC. I think it's OGAC funded, but it may also get support from a couple of foundations. And so I'm not sure what your particular question is, but so you may want to expand upon that. But there are a couple of individuals who we fund who are layering research questions on top of PrEP provision internationally. Um, as we've learned from the US, you don't want to make mistakes in PrEP provision early on. What we don't want to see is the same disparities in treatment in
Right.
PrEP. And so unless we do something different, that will happen, and even happen in low and middle income countries where um, they will want to provide PrEP to those at risk. What they need to provide is PrEP to those most at risk. And so part of the challenge internationally is trying to find and provide PrEP in a safe, sustainable way to those who are at highest risk for HIV infection. Does that answer your question?
Yeah, so the grant that I have under review right now, the one at the 10th percentile, is it's a PrEP focused, well, it's stigma related to PrEP uptake and adherence. It's stigma and medication concerns and beliefs among Black MSM in southeastern US.
Mm-hmm.
And I mean, I think um, it's helpful to know. I mean, I obviously, I've looked it up in Reporter, but it is helpful, and it's helpful to hear you talk about other projects like that or of a similar thread
Yeah.
to get kind of the best sense of, I mean, I want to go forward in that direction. I currently have funding to do, so we have a stigma intervention to increase HIV testing, HIV and STI testing uptake, and we've added in. I mean, that grant was not specifically funded to look at PrEP, but we've added PrEP in because it's like part of standard of care. How can we work with these guys who have 33% of them are living with HIV without at least discussing the provision of PrEP? So we've integrated it in, but there really needs to be a mechanism of support there to support basically the majority of participants who are very suspicious of PrEP.
Yeah.
So there's a lot of emotional, and once you kind of like peel back the onion a little bit, if someone says they're interested, and you start peeling back the onion a little bit and encouraging to take additional steps, you reveal the emotional component to taking PrEP.
Mhm.
And there needs to be some work done there before individuals are going to take it, or but even among the individuals who get it, after once they're in receipt of it, they stop taking it.
Mhm.
Um, so there's a lot of work. We've teamed up with some experts in medication adherence, or excuse me, medication beliefs and concerns, and we've brought in our stigma piece. So I think it's quite cool. And so it was just helpful to hear about the things that are currently funded. I'm familiar with some projects, but I would say I'm only familiar with a small handful. And you had mentioned that one project. And so I thought, I mean, that was really just the motivation behind asking it was what are kind of like, if you've mentioned stigma a lot, and of course you mentioned the HIV care cascade. You
Yeah.
didn't mention the PrEP care cascade, but I think of the HIV care cascade, step one is getting tested, learning your status, and you know what, I mean,
It was really only because of time and just trying to squeeze a lot in. And you know what I'll do as a follow-up to this, Lisa, just to underscore how high a priority that is for us, is there's a presentation actually. Mike Sterrett did a webinar um, for, I believe it was for one of the NIAID networks, that essentially summarized a great deal of the prep work that we're funding that I can send, and you can send out to the group of those who are, that was publicly presented. So you can send it, Aaron, in total to those who are
that'd be
interested.
great.
Yeah.
That would that would be great.
I mean, you may know this as well, but it's probably, it's estimated that perhaps only 3% of those who are at risk, who are minority MSM, are currently prescribed PrEP.
Right. That
So
would be consistent with what
yeah.
we see. We see about 5%. So yeah, and it's actually been fairly consistent over the past 3 years. So
I'll just do, there may be other questions, but in the interim, I'll just say, in terms of the implementation science space, it's just clear that even though the whole pie may not grow, that I think that there will be additional resources that are devoted to getting the tools into practice that we know work. We
right.
recently just convened a meeting. I know that a couple of people who are on this call were at in Chicago, across the Centers for AIDS Research that NIAID funds and we co-fund, and the NIMH centers. There's likely to be a few major activities that are coordinated, including probably a similar cross-center implementation science platform of some kind, which enables studies to happen um, probably faster and at scale. That's somewhat analogous, I think, to the New England Implementation Science Research Network that those at Yale and others in your Northeast have worked to
Yeah.
address the needs of the small cities.
I just sent you another email of a question. I don't know if you received it yet.
Yep. The upshot of this question actually relates to that New England Implementation Science Network, and the projects that have been funded to tap that network have tended to be smaller, seeded with pilot funding. And so I would agree, Elaine and others, that the time is probably ripe to have a consultation with the key folks from that network. I'm not sure whether that'll be a smaller tent or a larger tent to talk about the kinds of projects that we think are most um, that have the most traction that could come out of that network. So happy to coordinate that as well.
That's all I have on
That
mine.
is that may be all. I could talk for much longer, but I'm looking at time, knowing that folks may have to get off the call. But I really do hope that those of you who are listening um, got the message, if you didn't know already, that you should not hesitate to contact us, nor apologize for contacting us, nor thank us. Really, we are public servants, and it's frankly one of the most interesting, motivating parts of what we do is to help those who are doing all the work in the field to make competitive applications that we're able to fund. That's what makes us feel purposeful in our work here. So although I wish I could have been there in person, I look forward to meeting any and all of you at some venue, or reach out and contact anytime. We can have a conversation.
Chris, we really appreciate your time. Thank you so much for coming today.
Oh, you're welcome. Thanks for
Joining us.
coordinating. Take
Thank
care.
you, Chris. It was good
Yep.
seeing you.
Thank you.
Bye now.
Take care.